All right. Hi, everybody. If you hover your mouse over the bottom of your screen, the buttons for the audio on and off and the video on and off are located there. Attendees are advised that this meeting is being recorded, so anything said verbally, anything viewed via webcam, or anything typed in the chat will become part of the recording. We'll be displaying materials for the group, so if you want to present your screen, please ask. And we'll monitor the chat box for questions. And if you're attending by phone only, you may need to press *6 to unmute yourself. Thank you for your participation and patience.
Thanks, Shelley. So I figured we can just do some quick introductions really quickly while we're waiting. So hi, everyone. My name is Julia, and I'm the Time-Sensitive Illness and Injury Manager with the Bureau of EMS. And Adam, I will toss it to you.
Adam, I think you're on mute.
Darn it. Hello there. Thank you. My name is Adam, and I'm on Julia's team at the Department of Health Services as the EMSC program manager. So I'll be here at your disposal for whatever I can do for you in that regard. So I'm happy to be working with you all.
Okay, I'll go. I'm Sandee Nygaard. I'm the pre-hospital coordinator at Banner Ironwood and Banner Goldfield.
And I'm Mickey Kovacs, pre-hospital coordinator at Banner Desert and Banner Gateway. And I have a cold, so I sound real congested. I apologize.
And I am Jansen Neff. I manage the Pediatric Prepared Emergency Care Program at the Arizona chapter of the American Academy of Pediatrics.
Hi, Dale. We're doing some quick introductions since we have Adam on board today.
You might be on mute there, Dale.
Sorry, I stated my apologies. I was traveling between meetings, so I got to my computer here late. So
yeah, no problem.
Is Adam sufficiently introduced?
Yes, I think so.
Yeah, I did. Thanks, Dale.
All right. I'm looking at Shelley and Julia's agenda. Now Adam's. Do we need to formally review the meeting minutes in advance, Julia, or I think
we can do that really quickly. Okay. They're pretty brief, so we can just kind of review them.
Okay. Okay.
It's not a voting item. Just if anything needs to be edited, please let me know.
If I'm not out of order, I would move to accept.
Great, thank you.
I need a second.
This is Sandee. I'll second.
Thank you, Sandee. Okay. So while we're displaying the minutes, the big focus, and I think we had everybody on the last meeting, our big focus was the brainstorming component. And I will speak for myself in that I'm still a little bit stuck as to what's the best impact PACES can have with behavioral health. One of the things that we are all very acutely aware of is behavioral health is a big problem across the state. and the logjam is more in the emergency departments and their disposition to the appropriate behavioral health facility, maybe not as much in the pre-hospital environment. So for that reason, we were all going to go out and I think do a little bit of homework, see what other people are doing, what else is there, beat the sidewalk, find out from our colleagues what impacts we could have. And this is kind of where I open it up to the group to report back and see if you guys have any insights or suggestions going forward.
Well, I think part of it is a lot of it is that there's not enough space for behavioral health for the kiddos. We're stuck with them, as you well know, for hours upon end. We're lucky enough to have a child life specialist at our facility who is able to do some work with the kiddos. But the biggest thing I've heard is there's no way to send them to, which I understand that we can't solve that problem. And the ED is really not equipped to deal with behavioral health kids. So that's what I have heard. There is some talk of the potential of looking at alternative destinations instead of them coming to the ED. If we can work out arrangements to where if they're not, it's not a medical problem, if they're purely, just angry or depressed, or that they could go directly to a behavioral health facility that would, circumvent having to go to the ED for medical clearance, which a lot of times they don't really need. So that's kind of what I found out from my little group.
Thank you, Sandee.
Yeah, this is Mickey. Mesa, the city of Mesa is like one of the only recognized autism certified cities. It's on their website. I just looked that up. It's on their website. It's a credentialing from the International Board of Credentialing and Continuing Education Standards. And the entire city went through an autism education on how to handle autistic kids. It's actually very good. So that's one thing their fire department has gone through, is learning the autism part of it. The other thing I looked up was, because I was in Pennsylvania, so I looked up their EMSC. They have a very nice website on their EMSC, and you just click on like resources, and one of the things they have on there is education, and it has like Autism 101 for EMS practitioners. You can click on things like Frederick the Paramedic. It's a little coloring book that they can have the kids click on, but it's nice. It has a lot of resources on behavioral health and how for EMS to deal with them. So that was pretty cool.
Mickey, would you mind sharing those links with the group?
Sure.
That'd be great. I'd love to take a look at those.
The pediatric one, I mean, the EMSC in Pennsylvania was so easy. I mean, I just typed in Pennsylvania EMSC and it came right up. But I'll share that. I was shocked at how easy it was to find. Now,
Okay.
I tried the same thing for Arizona, and it took me to a bunch of different things. So the one for Pennsylvania was very easy and very user friendly. So I like that.
Yeah, great. So put that on our future list, improve our website.
Yeah.
It's on the list.
Jansen, any, and I'm not picking on Julia and Adam because I've already talked to them yesterday. So we had kind of a primering meeting yesterday. Jansen, any thoughts on your end?
The PPAC program works more like once they're in the ED, so I don't have a whole lot to say about what happens before that, but obviously I'm here to have the program help however we can.
Okay. So to drill down a little bit on what Sandee had said, we're all acutely aware that really it's the boarding and the placement, the ultimately locating these patients in the appropriate facilities is kind of key. One one of the things that, and Julie and Adam and I talked about these yesterday is I personally feel like I need to understand the Arizona system a little bit better. Now, in the old system, we had the REBAs, which was kind of the acronym for Regional Behavioral Health, and the Arizona was, sectioned out, and each REBA essentially governed the behavioral health facilities in that region, and resources and funding was distributed in that manner. When they reorganized, my understanding is one of the requirements, and maybe even a mandate of the behavioral health regions, but again, I'm using old terminology, is that they are able to accommodate crisis scenarios, which is one of the reasons why I'm aware of what's going on in Tucson, in that we do have behavioral health facilities that will accept EMS transport for that, and that was kind of a requirement that was delegated to them. Now, that being said, they're not going to take care of heavy medical cases. They'll bounce trauma back to the emergency department, anything that needs medications that bounce back to the emergency department. But they do have the capacity to de-escalate and take and do crisis intervention. So I think we need to learn a little bit more about that. If this is disseminating education to our regions, and maybe organizing it in a fashion in which we can help decompress the ED by one, that they don't have to go to the ED, they can go to one of these other facilities. The other option, if we're looking really at the impact of decompressing, is how do we cause more level 1 facilities to be created throughout our state? And that's outside of our lane. That's a statewide funding problem, and that's not something necessarily that PACES could focus on. But if we're disseminating education to the interventions that could occur in the pre-hospital setting, I think that's one thing to look at and maybe identify if this is an alternative. That being said, and Adam, maybe you can pick up from here, is what is the likelihood that an EMS agency, whether rural, urban, suburban, could de-escalate in the field and one, not transfer at all, and not transport at all, or two, identify those secondary facilities, and we actually create a culture change in the agencies to transfer to elsewhere, if there was one that was available. Adam, as a paramedic, what are your thoughts in that regard?
Right. No, this is aside from any interest in transport for revenue. If we move that aside from whoever may be transporting them, I can say that the awareness that the possibility exists for a transfer, if it has to be a transfer or transport to a facility that is other than the ED, is very low amongst the field practitioners. We don't generally know. I mean, maybe I don't know what the percentage would be. 1 out of X the pre-hospital practitioners will know about it. I just don't think the awareness is there. I know that there's a gap in communication as well, since we do a lot of radio patches. Well, I mean, we have to patch through every patient we're bringing to the hospital. That at least here in Southern Arizona EMS, the facilities that you were referring to that will accept transport from the field aren't programmed into our radios, so we really can't even talk to them as an alternative. And then to your other point about the treat and refer or non-transport at all de-escalation, I think that's the first thing that we're looking at and trying, because we all kind of register the fact that there may not be a medical component to this. It may entirely be behavioral. And so I think, I don't want to say like rewriting the orders, but making the field providers more comfortable with that as an option that we can kind of treat and release or refer. The way it stands out there right now is a lot of it, and it sounds terrible, but it occurs where you have the behavioral health patient stuck between EMS and law enforcement. And you'll have law enforcement saying they're a patient, and in some cases you'll have EMS saying they're they're a law enforcement problem, and they're sort of stuck in the middle here. And I think when we cast a net of education about perhaps there's another option for transport, or maybe a little bit looser or more, maybe not looser is not the great word to use, but a better defined section in the administrative orders for these pre-hospital providers, perhaps that would make them more comfortable to identify this as a ruled out medical causes, but identify this as a behavioral emergency, and therefore they can say, all right, well, treat and release is within my purview as a pre-hospital provider, or take them to a facility that is not necessarily an ED. I think those two things have room for improvement in that setting.
Yeah, and extending, Nikki, on the resource that you had identified, you know, if our paramedics had this type of education on autism, de-escalation techniques, would they be better equipped to be able to do what Adam refers to as essentially not ultimately leading to a transport? You know, and that's something else to maybe think about a little bit. And I want to qualify some of my earlier statements. I don't want to give bad information. I am not 100% of understanding the grounds or the parameters in which these outside facilities will accept patients from the field. I think we need to explore that. Would there be a benefit? I just thought about this while Adam was speaking. Would there be a benefit if the Bureau could identify a representative from the behavioral health parallel to us to come and join us at one of these meetings and explain all of the parameters and what the resources are and what the rules are? Should that be kind of a formal, we invite them to meet with us, or is this something that we should talk to them offline to be able to learn more?
I think that's a good idea. I mean, we're not experts in behavioral health, or at least I'm not. So I think it would be kind of very helpful. I will tell you something that came up here in Pinal County very recently. I had a meeting along with my medical director last week with GMR or AMR. And BANA has partnered with them for ET3, which is an alternative destination for patients. And we specifically asked them if they had worked with BANA Behavioral Health at all for us to be able to circumvent the ED for direct transfer to BANA Behavioral Health. They are looking into that. So that's something that might come up that might be useful for us. So they are looking into it, which they haven't recruited behavioral health, but when we brought it up, they went, oh, a light bulb came on. So that is something that is in the works for at least our area.
And Sandee, this is exactly what we're talking about. For those who aren't aware, TC3, I don't remember the acronym, to be honest with you, but it's that treat and refer paramedicine disposition in the field concept that the state is trying to evolve. Each agency who is interested in doing TC3 has to certify with the Bureau, is my understanding. If anyone else on the phone knows more about it, let me know. I didn't know AMR was looking into that, maybe, but AMR being statewide may be doing that just regionally. I don't know. But Sandee, this is kind of right up our alley. This is what we're kind of talking about: is how do we decompress the ED? One, not transport them if we don't have to, and de-escalate in the field. So yeah, that would be a huge. If you can. Be kind of a fly on the wall or participate as much as you can so we can get a report back as to what they're doing and how we can either help or participate. That'd be great.
Yeah, I will certainly do that because, like I said, they have partnered with BANA to be able to transfer non-emergent patients to the BANA urgent care centers rather than to bring them to the ED. And that's when we brought up, well, what about behavioral health? because that's what hangs out in the ED more than anything, and they haven't thought about that. So they, so both Banner and AMR were going to look into that.
Okay.
So they will get back to us. I guess they're starting this program. It's November the 1st here in Pinal, and then it's opening up in Maricopa and Pima County closely afterwards. But I talked to the crews and they hadn't heard about it yet. So I think it's still evolving. Yeah.
And maybe that's another question that we can put in for the kind of the interim time frame to work on is, one, what are the reimbursement structures for EMS agencies to, one, transport to the ED, two, transport to a behavioral health facility, or three, treat and refer. My understanding is treat and refer was about 1/3 of the reimbursement rate, but there may not be as much of a discrepancy between the reimbursement rate to a private company like AMR if they transport to the ED versus a urgent care versus a behavioral health facility. And I'm ticking through my fingers. I guess those weren't visible on the camera, but so yeah, that might be some homework to sort out, because if the reimbursement rate is no different, then there is no financial disincentive to choose that ulterior site. It's making sure our paramedics are comfortable in the field, identifying which patient is better located in one spot versus the other.
One of the challenges we have with that, because we do have some agencies that will take them to a behavioral health center, is they need medical clearance then. So sometimes they'll just get there and then they'll call an ambulance to transfer them here because they need to be medically cleared. Now, I don't know the exact number that is. One doctor I talked to said it's got to be huge. And the other doctor says, well, I know they take patients directly there. So that's mostly adults. It's harder with the children because there's not very many places that will take pediatrics directly. So, and again, I don't know how many, so it'd probably be nice to have somebody here who could tell us those numbers.
Yeah.
Yeah. Well,
and I'm sorry, I'm taking so much of the time, and if I cut anybody off, it's like flight of ideas. That's the hardest part, is understanding the resources in your community, because, we have, for example, Palo Verde and Sonora. Palo Verde will take down to 8 years of age, but Sonora will only take down to 12 years of age. So there's such a resource restriction that I think we need to understand that a little bit more. And I don't know why, or maybe I'm wrong, but it doesn't seem like it's being very well communicated from whatever bureau is governing the behavioral health services. Maybe there just needs to be better communication, and we can help facilitate that.
Group, I just looked something up, and the U.S. Department of Health and Human Services, ADHS, announced the emergency treat, triage, and transport payment model, which will make Medicare reimbursement available for certain non-transport ambulance services and ambulance transport to alternative destinations. So it's going to, it will be covered under Medicare and Medicaid.
Okay.
So,
does it have a time frame for that, Sandee?
Well, this was, I'm looking at when this came up. This article came out. It came out in, oh, well, you'll like this one. It came out in February 2019. Oh. We're a little bit behind, but it does say the pay model is designed to decrease the burden on emergency departments and connect the patient with the best place for care, which may not be the hospital. So they are going to be able to get paid for that, Medicaid and Medicare. So I don't know about other other insurance agencies or other insurance plans, but it definitely is those two. And a lot of the behavioral health kiddos that we see do fall under Medicaid.
Yeah. I would venture to guess that like a lot of these federal regulations, they have to filter to the state, and each state kind of executes them in different manners. In 2019, Arizona was, I think, commencing working into that, and that TC3 certification process started up. But again, I'm remembering this all pre-COVID. I think COVID's probably what put this all in a bubble. Well, everybody's time is valuable. Maybe thoughts for next steps, what we can do going forward. Is there anything particularly that you guys are focused on personally as to what we've kind of promoted a little bit more searching for?
I think last time we discussed briefly creating some sort of presentation on just and field interactions with behavioral health and being able to address those. And I think Adam prepared a couple of slides just as like drafts if we wanted to look at those or discuss that possibility further, if that's still of interest to the group.
Adam, you want to share screen?
Sure, give me just a quick moment. Let's see. I don't have them pulled up immediately, but I should be able to get them pretty quickly.
While you're doing that, Adam, the resources that Mickey found for Pennsylvania, if that's EMSC funded, it is public access. It's non-proprietary because it's federally funded. So we can be diplomatic and ask them to share it with us. But taking any slides from that set and adding them to what Adam creates, I think is going to be all fair game.
And I didn't really know, just a note that it wasn't really certain about where to start with these, but I thought the best place to do that would be from just the most basic level of understanding, just to kind of give it the biggest bang for the buck, so to speak. So I just kind of started to put together, sorry if I'm kind of jumping around there. Started to put together just a general outline. If you were to take this to maybe an ED or a fire department or something like that, and just use it as like a baseline. And it's not complete or all inclusive, but it just helps to give some introduction background, maybe some identification of different types of illness. To that way, it allows that provider to maybe make a decision based on perhaps what kind of disorder that they identify in the pre-hospital setting. And things of the like. But it is in the share folder. We can get this out and able to be edited or whatever have you at your guys' discretion, whatever you think.
Adam, would you mind going back to your objectives, please?
Oh, sorry. Let's see. Okay. Hopefully you can see that.
Maybe another bullet that actually addresses some of the decisions in the field. So maybe apply behavioral health understanding to ultimate disposition and transport decisions.
Right. Yeah, absolutely. That makes perfect sense, because that has to be the usable goal, I suppose, of it.
I think one objective, would be to understand your own community's behavioral health resources.
Oh, absolutely. Yeah, I agree with that.
I just started, and then of course I got super busy and it went by the wayside. A couple of PowerPoints. One was, what is a pediatric behavioral health emergency? So I just did bullet points for critical when a behavior is disturbing or dangerous to a child or others.
Okay.
And that psychiatric emergencies in children are rare. They not always stem from mental illness and more likely from situational, medical, or injury problems. And then the second one I did was on stressful situations. What are they? Abuse or neglect, normal emotional upheaval, pregnancy, and a traumatic event. That's as far as I got. Sorry.
No, it's perfect.
Next slide, please.
Oh, sorry. Apologies. A little background.
Yeah, I'd hate to imply that we don't think our emergency departments can manage them. We're not effective at managing their behavioral health. We're effective at managing them medically. We keep them from hurting themselves and others.
Right.
Just wondering if there's another way of wording that to make it not
Yeah.
necessarily as critical of our systems as much.
Very good point.
Yeah, most emergency systems are not adequately prepared to effectively manage behavioral health patients or behavioral health needs. Yeah. And it's really the chronicity. I mean, we can take care of them through their crisis.
Mm-hmm.
It's just their ongoing needs, their chronic needs. De-escalation, we can mull that over further.
Sure.
Um,
And then a little bit on that background to maybe give the reader a sense of how often they may encounter these patients or proportions of differences in the particular diagnoses, which is what this slide is sort of getting towards.
Adam, is this national data or Arizona regional data?
This is, let's see, this is off of Centers for Disease Control.
If
figure here.
if ADHS has a state report, I'm expecting they do. It'd be nice to add some state-specific information. And I very much like to, include the geographic areas of Arizona. I mean, particularly the rural areas, because the rural areas tend to be the most under-resourced. So we'll see if we can dig into some local data.
It's a good idea. Yeah, absolutely.
Next slide when you get a chance.
Sure. And then after that background, a short introduction. Again, it's not all encompassing, but a short introduction of some of the most common types of disorders. And that, I think this arms the pre-hospital provider with some information to make a bit of a field diagnosis.
Okay. Next slide, please.
Sure.
If this is going to be pediatric specific, should there be a comment about identifying legal guardian?
Oh, absolutely. Yeah, that is a frequent item to talk about in the pre-hospital setting with the ped is who has the ability to say what they do. So yeah, it's absolutely reasonable. And this slide was just to help differentiate some awareness of that they weren't making a false diagnosis, utilizing the rest of the tools in their toolbox to kind of take a look at their patient in their entirety and make sure you're not missing an underlying medical emergency. But again, it's not all encompassing. Those were just the three most prominent things that kind of jumped in my mind that can alter pediatric behavior.
As was mentioned earlier, true psychiatric illness is pretty rare in kids. And very often the rule is that there's an organic cause, meaning a medical cause.
Right, exactly.
So one of the things that we focus on is whether or not there was a pre-existing diagnosis. If this is consistent with their prior diagnosed anxiety disorder, previously diagnosed schizophrenia. Absolutely. But if it's new onset psychiatric, those are the ones we really do not want to treat and refer. They need to go to the emergency department.
Right, absolutely. Which is sort of a foray into the next slide, which is not really well developed, but to give the idea that whoever we do identify with that legal authority to ask them what's going on to help make that differentiation perhaps between a new onset behavioral problem and something that's been chronic for that patient. And then the next slide, utilizing de-escalation techniques. I didn't get into any specific techniques other than to just take a look in the textbook about what it has to say about these scenes, and that is generally what you see there is find the person that the patient most greatly seems to have a rapport with. And then after that I didn't sort of finish the slide set, but that's where I'm leaving off right there for just a moment.
So Mickey, when you reviewed the Pennsylvania materials in the slide set, do you think they would have some slides that we could pull into this de-escalation component?
The only one I saw on anything behavior health was the autism one. Yeah. I'm trying to going through some of their stuff right now. They have really nice stuff on transporting kids. There's stuff about suicide. It's mostly CDC information, but it's very nice. I'm sure we could pull it into ours. It does have some, the big thing on suicide, youth suicide. But I didn't, and then there's something on bullying and cyberbullying. I don't know if we could use that too. That's a big problem with behavioral health in kids. But it is very nice. It's a nice website. And it says most of the slides, like they'll say, obtained from NHTSA. So I'm sure there are things we can use. Yeah. And the CDC stuff too.
I'm sorry you're seeing two of me. I guess I have logged in twice because I disappeared and logged in again. So I apologize. Two of me is way too much.
It's all right.
I'm posting a resource that I found I'm posting a resource that I found, sorry, in the chat from another state program. We might have to fact check some of the information, but it could have some good starting points in there as well.
I don't know if you guys are more Google Meeting privy, but I'm trying to cut and paste those websites that you're sending out, Julia. I think I'll just, you know what? I'll just email them to myself. Just so I have them and I'll look at them after the meeting. Thank you for those.
Yeah, I think those contain case studies, and I think those are kind of important when you're doing the actual education to give them the situation. So that's really good, Julie.
Yeah, we could definitely reach out to them to see if they have any problem with us using any of the information that they posted, but it seems like it's there for us.
Yeah. Look at the end recognitions or the funding sources for the slide set, and if they state EMSC and or federal funding, then it is public domain. But yes, I agree with you, Julie. I think for diplomacy's sake, it's nice to reach out and make those connections with our partners in other states. I just pasted your links into an email, Julia. Sorry, I didn't know how to necessarily follow them, and I don't multitask well, so I'll look at them later.
That's okay.
Okay, next steps.
The next steps that I have written down are to find a behavioral health contact, maybe at ADHS or Access. I'm not sure where, but we can ask Rachel, probably Adam, to help us out with that. Look into some of the treat and refer. You were talking about the reimbursement structures, so that could be interesting to find information out about. And then if we want to continue working on the slide set, as well as just a resource to have.
Julia, Adam, either of you, would you be willing to compile the questions that we have? And then we'll have them kind of in a written format. So if we contact this behavioral health representative, maybe we can, instead of a group meeting, we can get the questions answered individually and then come back to them. If you guys have those questions and email them out to the group, we'll keep adding to those questions, and then we'll assemble the list to be able to tackle this individual we find. Would that be okay?
Yeah, absolutely. We can take care of that.
Thank you. And then, yeah, we can keep working on the slide set. Do you want to volley it back and forth by email a couple of times, and then we can set up our next meeting?
Yeah, absolutely. I would hate to get too far into it and have a bunch of adjustments to be made. So it would be useful if I could just kind of make revisions and see what everybody thinks as we move along.
Okay. Should we look at a couple of weeks for our next gathering? When do you guys want to meet again?
I think Adam and I are probably fine with whenever the group wants to meet. So if you guys have any specific weeks that work best for you.
As long as it's not the third week of the month.
Okay. do we want to try to look at the calendar right now so we can just get something on the calendar? Or we can do a doodle poll again if that works better for people.
I think the Google one's pretty good. You give us choices and we can tell you what works best for us.
Okay.
Okay. I will send that out to us after we get done here so we can kind of start taking a look for another meeting.
Great. Well, without further ideas, should we go ahead and adjourn?
Yeah, I don't have any more brilliant ideas this morning.
Me neither.
Mickey, how about you?
I'm just trying to type in things. There is something on a New England Regional Behavioral Health Toolkit, training videos on the approach of the pediatric ED patient with behavioral health condition, de-escalation tools. That's kind of cool. I'll send that out.
Yeah.
I'm just typing in, like simple things, and some good things are coming up. So
Yeah.
I found when I try to type things in when I'm on this meeting disappears. That's why you have 3 of me and I bring it up again. Such is life.
Okay, well, I thank everybody for your time. Great job on the homework. I think let's all take a look at those resources, and we can start making a list as to what resources of the toolkit. I mean, we don't have to just do a single slide set over time. We can reach out to the authors of those other items and see what's available, and then we'll keep chugging from here.
Sounds great. Thank you.
Thanks, everybody.
Thank
Thanks.
you, everyone.
Thank you.